Welcome, ladies and gentlemen, to this session titled To Stand or Not to Stand, and we're going to discuss a couple of complex PCI cases. I would like to think that you should attend this session if you want to discuss and learn about cases and decide if all the procedures that are presented require stenting. And this session is with a particular emphasis on the use of drug-coated balloon. And we are going to discuss specifically on DCB with regards to indication of its use, the importance of vessel preparation prior to DCB, and subsequently in assessing the results post-DCB. As you know, with regards to the accepted or established indication for the use of DCB, and particularly the paclitaxel DCB, it is in the use for treatment of in-stent restenosis and for small vessel disease, where there's fairly strong data. There are other circumstances that are listed where you can use and utilize DCB, for example, in bifurcation lesion, in de novo lesions, and the others that are listed. When you look at the technology of drug-coated balloon, the drug is coated onto the balloon with an excipient, and this is called the matrix coating. When the balloon is inflated, the drug will then go into the tissue and afflamatous plaque. And the fact that it is coating throughout the balloon, it gives a more homogeneous elution of the drug into the tissue. So when you look at some of the advantages of using DCB, besides homogeneous drug elution into the tissue, you do not use a stent. Therefore, the risk of stent thrombosis is not evident. And when you treat patients' lesions that have the side branch, there will be no stent struts to obstruct the side branch ostia. There is a potential that you can use a much shorter DAPT duration, and you allow the vessel to function normally since the vessel is not caged by a metallic stent. At the same time, there has now been shown that in a substantial number of patients, in at least 70% of patients, you actually have late lumen enlargement of the coronary arteries on follow-up assessment by an angiogram. So this is something which is good because you can actually have vessel enlargement leading on to lumen enlargement. So what we are going to discuss are the cases, which is number one is de novo proximal LED stenosis, and secondly, bifurcation lesions. And to assist me in this presentation would be my two other panelists, colleagues from UK, Dr. Simon Eccleshall, and also Dr. Bruno Scheller from Germany. And we hope that at the end of this proceedings session, you'll be able to understand and appreciate the use of DCB in the complex cases that we are going to show for you. So I'm going to share with you a patient with a de novo lesion in a proximal LED. And we'll see how we're going to treat this or manage this patient. This is a 62-year-old gentleman with familial hyperlipidemia, and I've been treating him for more than 20 years. He had an inferior ST elevation MI in 1997, and he had PCI to the right coronary artery, and this was during the time of bare metal stents. In the year 2002, he had a PCI to the left circumflex lesion, and in 2015, 13 years later, he had in-stent restenosis in the distal right coronary artery. This was treated with a drug-coated balloon, and there were new lesions in the proximal and mid RCA, and this was stented from the ostial to the distal right. He remained rather well, but on assessment by a stress echo in October of 2018, there was ST depression noted in the ECG, and there was stress-induced ischemia with hypokinesia in the LED territory. So we suggested that he should undergo a repeat angiogram, and this was done about 2 months later. These are still images to show that there is significant stenosis in the proximal LED. And these images are to show that there are also fairly significant calcification in the proximal and mid LED. This is a picture of the right. The stents in the right are patent, and the distal segment into the PL branch, the side that was treated with DCB, was also patent, and the flow was good. there was only an occlusion of the PD branch. The other images also showed another lesion in a fairly sizable high obtuse marginal branch. There was stenosis in a proximal segment at two sides. So what we did was we prepared the lesion in the LED, and in this case, I elected to use a scoring balloon. And at 18 atmospheres, the balloon was rather full and there was no wasting of the balloon seen. So at least the calcification showed that the lesion gave way with the scoring balloon. And this was the results after. Perhaps you can play the images. Thank you very much. And you can see that the flow is all right, but there is a dissection seen at just before the bend. And you can see that there is some dye which is holding up, and it was fairly persistent at the end of the injection, but the flow was STEMI-free flow. So my question to you is, how would you treat this patient? Especially this is a lesion in a proximal LED, a de novo lesion, and that is a type, I would probably say a type C dissection, but with good STEMI-free flow. So once again, let's have a look at the images, moving images of both for you to appreciate the lesion and dissection, and with some persistence of dye. So let's open this discussion within within panelists. Perhaps you can bring back Dr. Simon and also Professor Bruno Scheller on the screen, and we can actually discuss how they would take and treat this this current situation following vessel preparation. So let's start with Simon. How would you go on, Simon? Do you think that the dissection is bad, that you think it should be stented?
So my initial interpretation of the angiogram is you've done a very nice lesion preparation with an appropriate sized balloon. You have TIMI-free flow at the end of the procedure. The patient presumably has no chest pain. The only outstanding issue really, as you've highlighted, is that you have some contrast staining which persists, which would classify it as a type C dissection. But I think we've now all learned that the old dissection grades are perhaps a little bit open to more interpretation than we used to think so, particularly in the setting of better angiography and the use of dual antiplatelet therapy. There are a number of ways you could approach this. One would be that you just wait for a considerable period of time to see whether there's any limitation of flow. Another would be that you could go back and do further lesion preparation. And certainly in my practice, what I've found is if I can't make my mind up as to whether or not I've done a good enough lesion preparation, if I go back again with a cutting or scoring balloon, perhaps slightly higher pressure or for a little bit longer, after that, it tends to clarify the situation one way or the other. Either I now have an extremely good, stable result, or I know that it needs stenting.
Bruno, before I ask you how you're going on to treat this patient, do you think that you would treat the vessel or rather prepare the lesion in other means, or do you think it was adequate? Because I found that at 18 atmospheres, the balloon was quite full, and I thought it was enough vessel preparation. What would you do?
My general concept is the same as you did. Start with semi-compliant balloon sometimes and use scoring balloon as often as possible. I would have thought about using in addition non-compliant balloon with very high pressure due to the huge amount of calcification which is in the area of the lesion. Furthermore, I agree with Simon that maybe I would have done another 1 or 2 longer inflations with the scoring balloon just to see if I can modify this dissection. Sometimes it's possible to put it more to the wall and bring it to a type B dissection. But this is only trial and error. And you can't really predict what the outcome.
So if you were to come back now, you're looking at the lesion post balloon that I've done, and that was the stage I was. Would you consider stenting? Are you comfortable with that type C dissection, or would you say that, as Simon said, maybe you wait for a while and see the results and then decide whether you need to stent or DCB that lesion?
If we go back to the DCB consensus group recommendation, This is clearly type C dissection, and this means it should be stented. This is a very simple answer. However, the more you do in DCB-only treatment over the years, the more experience you gain, you learn that not every type C dissection is the same. And the next question is the flow good enough to take the risk and leave it without stenting? And then meanwhile, I tend to use in this situation additional tools like FFR measurement, and then decide what to do. This means if I would have an FFR of only 0.8, I would tend to stent it, to be honest. If it's better, if it's 0.9 or 0.85, something like that, I would try it without stenting. So that's not the way our consensus group recommends it, but I think it's feasible and it's safe in my experience.
Yeah. So coming back to that, Simon, because both of you are in the International Guidelines Committee. So you did say that one is FFR of at least more than 0.8. In your own practice, Simon, do you frequently use FFR to help you guide in terms of treatment and use of DCB?
To be honest, I don't, and that's partly because I relearnt my angioplasty based on and just the angiographic result. Occasionally we use pressure wires afterwards. We use a lot of pressure wires to decide whether or not we're going to perform angioplasty in the first case. When we do have pressure wires in at the end, then we're certainly working to at least make the lesion non-ischemic. I think there's a lot of interest and work and discussion around what results you need in order to be able to safely leave it. Anecdotally, I have seen a few cases whereby with a pressure wire in situ, dissections that are causing a problem, you can actually see the gradient increase as the dissection and the hematoma progress. And I've seen a couple of those, which is very interesting. So short answer, no, I don't use FFR most of the time. Certainly to guide my DCB result, because quite often we're not actually working on a pressure wire.
So I'm just going to spend just a bit more with regards to FFR, because this is something new in the guidelines and also our own Asia Pacific panel guidelines for DCB. So the principle for FFR is really to identify lesions that would be able to be acceptable for DCB and therefore reduce the risk of converting to a DS. So it's like Simon said, how long do you think we should wait a while before we measure with FFR? Do you think almost immediately? Because it does take some time to prepare the FFR and run through the adenosine. So probably by the time that you run in and you've got a fairly acceptable results, then it will tell you that it is quite appropriate to use DCB if the FFR is good enough. As in the guidelines, at least more than 0.8.
I think the setup time is a reasonable amount of time to wait. Yes, I'd agree with that.
Okay. Is there any further discussions or further important aspects with regards to vessel preparation that we need before we go on to see how I did the procedure?
No, I think you've done a very nice procedure there. One thing we tend to do is we don't go to such high pressures immediately. And I probably spend all day in the lab and might not go over 6 atmospheres with any of my balloons for a whole day. And then we go to higher pressures if necessary. And as I perhaps mentioned earlier, we have a checklist for after the angioplasty, which is, do you have TIMI-3 flow? Is there a vessel-threatening dissection, which obviously is one of the things open to discussion at the moment? Does the patient have any pain? Is there contrast in a particular bit of the vessel that's remaining there for a long period of time? Because that's certainly something that would then prompt us to look at it in more detail, or wait for a bit longer, or perhaps, as you said, go for an FFR.
Okay, so perhaps we can just go back to the case, to my slides once again. So this is where we left. So I did what was, how I treated the patient. I, followed as what you suggested, what you actually offered. I waited for 5 minutes and I took another shot, and the results were similar with TIMI-3 flow the residual stenosis is less than 30%. So I said, this is something that perhaps we can try to do with DCB. And I used a 3.0 by 40 mm. I inflated at 10 atmospheres for 90 seconds. And that was the results after, so fairly pleasing. And there was no compromise in flow or worsening of dissection. And to ensure that the results are sustainable, I treated the high OM lesion first. So at least after treating the high OM lesion, and when I come back and take the final shot, if the flow is still good, results are still acceptable, then I know that the risk of abrupt closure is going to be very low. So the high OM was treated with a 2.0 mm regular balloon, and that was the results after. Once again, it looks fairly pleasing. There is some mild dissection, non-flow limiting, and the TIMI flow is TIMI 3. And I also elected to treat that with DCB 2.25 by 15 mm at 7 atmospheres for about 80 seconds. And this is the results after. You can see that the OM lesion is acceptable results, even though there's dissection noted, a bit of haziness, but the flow in the high OM is very good. And this is 15 minutes post DCB. When you look at the results in the LED, 30 minutes after DCB, you can see that the persistence of dye is still there, residual stenosis is less than 30%, and the flow is still TIMI 3 flow. And this was also seen in other views. So we decided to accept this, and he did very well. There was no chest pain, no new ECG changes. In fact, there was no significant CK leak, and he was discharged the following day. We had a chance of bringing him back to be restudied 7 months down the line. And here you see the high OM lesion that was significant now turned out to be much better. There is hardly any significant residual stenosis. And we also looked at the LED, and the LED is still very good, and it's similar to the point that post-index procedure 7 months prior. And just to show you the flow is good. The contrast holding up is no longer there, so the lesion has healed. And therefore, with regards to the summary of case, I showed you a de novo proximal LED lesion. I think that what has been discussed is that lesion preparation is key, especially when you want to consider DCB. The decision, of course, that I had was whether we can use DCB or stent, especially when there was a type C dissection. But in this case, I really want to try and plan for DCB. So I needed to be a bit more patient and then restudy after waiting about 5 minutes. And when it was still very good flow, this suggests that if I were to use DCB, the risk of abrupt closure and conversion to a stenting is going to be very low, as what is seen in this patient. And we have also discussed about the use of FFR for the treatment on the use of DCB and to assess final results. I just want to highlight what is the latest DCB-only strategy for PCI guidelines by the International Guideline Committee, of which Bruno and also Simon is part of the committee. So the importance is really with regards to optimal lesion preparation, and this is by pre-dilatation with either standard balloon. And in this case, since it was calcified, I decided to use specialty balloons. And what is being said as specialty balloons are scoring balloon, cutting balloon, non-compliant balloon, and sometimes you may even have to consider atherectomy by rotablation or orbital atherectomy system with the diamond back system, or even with shockwave balloon. And we have also discussed about FFR measurement that may help to guide our PCI. So once after optimal lesion preparation, we will have to assess if the suboptimal angiographic results, which is flow limiting dissection, residual stenosis of more than 30%, and if you use FFR is low, then you have no option but to treat with DES. But if you have acceptable angiographic results, and these are important, guidelines in terms of non-flow limiting dissection, less than 30% residual stenosis, therefore you can use DCB and therefore get fairly good results, immediate and hopefully in the long-term results.
So it's my pleasure to be invited along for this discussion of complex angioplasty, particularly focusing on drug-coated balloons and whether or not we should be using stents. My name's Simon Eccleshall. I work in the UK. That I'd like to present is bifurcation angioplasty. So setting the scene, this is a 58-year-old gentleman that was admitted to our hospital with an anterior non-ST elevation myocardial infarction. This was confirmed by enzymes, anterior T-wave changes on his ECG, and a hypokinetic anterior wall on echocardiography. When he was taken to the catheter lab, pictures of his right coronary artery showed that his distal left anterior descending artery was collateralized by a large epicardial vessel, and he had a very complex LAD D1 subtotal occlusion. So we went on to wire both branches and then used a 3.0 non-compliant balloon within the LAD in order to more clearly define the anatomy and decide on our treatment strategy. So we wired both branches of the LAD and diagonal, used a 3.0 non-compliant balloon within the LAD, which, as you can see on the right, then more clearly defined the anatomy, so we could work out our treatment strategy. As you can see, there's a long LAD lesion and a long diagonal branch lesion with a true Medina 111 classification. And I'd like to open up to discussion with the panel as to how they think we should progress in this case. So if we can have the panel members up on the screen, please. I'd like to perhaps ask Bruno first, what he thinks of the anatomy and how he'd like to take the case forward.
So I'm thinking about what to do with the diagonal branch. You did only pre-dilatation so far for the LAD without a relevant occlusion of the origin of the side branch. So there are two options, in my opinion. There could be a very simple strategy, only treating the LAD and only treating with DCB, because we know that we have lumen enlargement in the majority of cases over time, and this includes also an improvement of the origin of the side branches. So this would be a very simplistic way of doing this procedure. The other option, which I would prefer in this situation, is to predilate the diagonal 2 and optimize the predilatation result of the LAD, and then finally treat both branches with DCB if possible. But this is a more complex procedure, and maybe the simpler version would also be a good option.
So Simon, I think a lot of people will just stent the main vessel, which is the LAD, and see the results, whether they need to treat the diagonal. And for some people who actually use DCB, they would then think about treating the side branch with DCB. But the only concern I have in this is that, number one, it is a bifurcation lesion. So any stenting of the main vessel can impede the flow in the diagonal, and you may have difficulty in trying to rewire. Secondly, there's also a large septal branch. And once again, if you put a stent across, and you might actually lose that septal branch. So in cases like this, I would try and see, after pre-dilatation, I would, in this case, probably use a scoring balloon in the main vessel, and then see the results. If the results are acceptable angiographically, and then I would consider using DCB as much as possible. If the flow is not good, obviously I need to stent that. I would think that the diagonal, being a large diagonal and it's diffusely diseased from the ostium to proximal, requires to be treated. So I would again predilate the diagonal and see the results, and I would then treat the diagonal. If I were to be able to use DCB for both main vessel and side branch, I would. It doesn't really matter where I would treat first, either main vessel or side branch with DCB. But if I do need to stent the main vessel, then it is my practice to DCB the diagonal and then put in the stent, because it's so much easier to treat the side branch first before putting the main vessel stent. And sometimes after putting main vessel stent, you might have difficulty trying to cross into the diagonal. So vessel preparation is key for both, and then I will decide on subsequent treatment strategy. But DCB if it's possible.
So I think you've raised a very interesting point, and it's one that gets asked a lot, which is if you're using a drug-coated balloon in the side branch, do you do this before or after stenting the main vessel, if your strategy is a stent in the main vessel?
Yes.
My approach is, I think, the same as yours. If you know up front you want to treat the side branch, you treat that first with a drug-coated balloon, and then if you have to stent the main vessel, stent it, and then not pursue the side branch again unless you've got a problem with flow. The only time really, therefore, that you use drug-coated balloon after the event is in a provisional approach where you have to go and chase the side branch because stenting in itself has therefore compromised the flow. So generally, most DCB outside stents and side branches is performed beforehand in a planned manner, and a few are performed afterwards more as a bailout approach. So what I'd like to do now is go back and show you exactly how we did the case, so we can have the angiogram. So that's the 3O non-compliant balloon, which defines the anatomy, and to my mind shows that we have a lot of disease within the diagonal branch that we felt needed treating, and there's a long LAD lesion that's a lot larger than the 3O balloon that we've just used. So we went for approach similar to, I suspect, what both the panelists just suggested. We used a non-compliant balloon in the diagonal branch back up into the LAD, and then a larger 4O non-compliant balloon along the length of the LAD lesion. As I mentioned earlier, we tend to use lower pressures perhaps than some other operators. And I think if the balloon is fully dilated at 6 atmospheres along its length, we would accept that as a good first attempt at a balloon result, which obviously is then dictated by your angiographic outcome. This was the acute result after using balloons that we felt were the right size for the diagonal branch and for the left anterior descending artery. I think there's a small degree of recall perhaps within the LAD, and I'd like the panelists to now tell me what they think of our angioplasty result, and hopefully they liked it, but also what they now think their treatment strategy is going to be.
I think the results are fairly good, acceptable results, because you can see that firstly the flow is good, there's hardly any dissection, and there is the residual stenosis is less than 30%. So I think both the diagonal and the LED showed acceptable angiographic results. In fact, if you were to ask me the concerns about which is a concern about especially abrupt closure or long-term poor outcomes, then I would actually accept a dissection which is non-flow limiting better than a residual stenosis of more than 30%, because the risk of coming back will be much less in my experience when you have a non-flow limiting dissection. You have drug which is penetrate deeper into the tissue, the vessel will heal, and subsequently you can have vessel enlargement. So coming back to your case, Simon, I think it's ready to use a DCB. I would use DCB for diagonal first and then the LED. And I would then see the final results. If they're still good, then I would be happy with the results.
The diagonal branch has some haziness, I would say. So this is not a perfect result for DCB treatment. And if this have been the case in the LAD, I would not be satisfied, to be honest. But for diagonal branch, it's fine, I would say. And the LED has very good result after predilatation. And it's interesting to see that you used a 4O balloon for this predilatation. I would have taken a 3.5, to be honest, in this situation. But it's interesting to see that if you use a bigger balloon with low pressure, you may have such nice results. So that's very interesting, I think. And for the strategy, I fully agree what Rosli said, the same strategy.
Thank you. So if we are now heading towards drug-coated balloons, how would you intend to do this? Would you use any kissing? Would you kiss with the drug-coated balloons? Would you use one drug-coated balloon and a non-compliant balloon in the other branch, or would you just keep it very simple with sequential DCBs?
So one of the critical issues when using DCB is time to deliver the drug to the lesion. That's one of the things you have to learn when you use DCB. And this means if you try to do kissing DCB, then the first balloon you insert will stay too much long in blood and will lose drug from the surface. Therefore, I strongly recommend to use it sequentially and start with the diagonal branch and then use it in the main branch.
I fully agree from that point of view. In fact, if let's say I were to use sequentially and I find that the results are acceptable, I would actually stop there and not have any kissing at all. But if you decide in the end of having kissing, that it should be low pressure to ensure that you avoid dissecting the main vessel. That's number one. About putting the drug-coated balloon sequentially, it depends also on the size of the guiding catheter you use. So if, for example, you use a 6 French guiding catheter and you dilate the diagonal, it would be better to actually remove the catheter and then remove the balloon and put in a new balloon, just in case, if let's say your balloon cannot go through, then you may have to retract the balloon, and then by that time there's still some amount of drug which has been eluted from the balloon. So I think in terms of quickness, rapidness of trying to deliver the balloon, it would be safer to do sequentially with one balloon out before you think about wanting to kiss, if there is a need to kiss.
So thank you. So thank you for that last point. I think it's very interesting that drug-coated balloon angioplasty, being partly driven by the fact that you have to deliver the balloons within a short period of time, actually makes the procedure a lot more simplified in these complex settings. So sequential drug-coated balloons is a much easier, more straightforward approach, and you are driven by the fact that you have to deliver the drug within a short period of time, but therefore your procedure becomes easier, and the need for ever doing a kissing balloon is not quite zero, but very close to it. So if we could go back to my angiogram again, please, and I'll show you what we decided to do. So that was the acute result after what we thought was fairly good, if perhaps optimal, balloon angioplasty. So we then used sequential DCB, so a long 2.5 drug-coated balloon in the diagonal branch. We go for an inflation of usually 6 atmospheres for 30 seconds. We then used a long 4.0 drug-coated balloon within the left anterior descending artery across the diagonal branch. Again, low pressure, 30 seconds only. And the acute result looks like this. So the checklist that we run through in our department would be, is the patient well? Do they have any pain? Do they have ECG changes? Is the TIMI3 flow in the vessel? How much recoil can we see? Is there a vessel-threatening dissection that we're concerned about? And in particular, as always, is the contrast accumulating and hanging up in any part of the vessel that we've just treated, which would then trigger us to look at that part of the vessel in more detail. So that's the checklist that we run through. And again, I'd be interested to know from the panel what they think of that acute post-DCB result.
Very nice result. My little concern remains with respect to the diagonal branch. There is dissection, there is haziness, and I'm not sure if we fulfill the criterion of less than 30% residual sources in this case. But I would leave it like it is. Why? Because you have a good flow. TIMI3 flow is clearly there. And we can expect that there will be lumen enlargement over time. So the hope is that it will look better after a few months. And it's only, in brackets, a diagonal branch. It's not a main branch. Therefore, I'm satisfied with the diagonal, and the LAD looks really fine. So that's a perfect result.
I wouldn't have any other different views from Bruno, because I would accept these results. The only slight difference, perhaps, if I were to do this case, is I would choose a slightly shorter balloon for the LED, because the balloon is very long, and my concern will always be that the risk of dissection in parts that you may not want to treat in the end. So other than that, I would agree with the way that you've done it. It's just a shorter balloon for the LED. That's about all.
Okay, thank you. I didn't, for brevity, I didn't actually show that we used that short 4.0 non-compliant balloon over a much longer course of the LAD.
All right. Okay.
So we were covering everything that we'd lesion prepared with the 4.0 balloon beforehand.
Yeah,
so
but that's very important. That's very important point, Simon, because everywhere they touch, you should actually treat with DCB and avoid the geographical mismatch. Yep.
I think it was the size of non-compliant balloons that we had on the shelf at the time. We only had a short one, so it just meant for more inflations. Yeah. So if we can now go back to the angiogram again. So this was the acute result. And obviously what we would also be very interested in is the sustainability of the result. So this is the 4-month angiogram. Rather than me describing it to you, I'll ask my panelists again what they think of the 4-month follow-up result. Perhaps we start with Rosli this time. Only if you tell me it's perfect.
Well, there is still some residual stenosis. I was really hoping that there would be some vessel enlargement over time. But really, even with the residual stenosis, it's not significant and the flow is good. And this is something that I'll be very happy about, especially knowing that you can leave nothing behind and you avoid putting in stent in the LED.
With respect to the diagonal branch, there is some lumen enlargement compared to the acute result, and very importantly, the dissection is healed, and that's one of the important things. If you start doing DCB only procedures, you should have angiographic follow-up in those patients to learn what happens with the dissections, to see that if you have good flow acutely, it's safe and you have improved long-term outcome. And that's really unique for this technology compared to stent treatment.
So this was the 4-month follow-up, and I agree with Bruno that what we've shown quite nicely there is that the diagonal branch has some late lumen gain, the left anterior descending artery doesn't, but I certainly think it's a good enough result. And as the patient was asymptomatic, this is a great case to, I think, show the point. So if you go to my last slide, I think what I'm trying to get across from the point of view of bifurcation angioplasty is it is more complex, particularly when you start using stents. And the more complicated your stent strategy, the more complicated the angioplasty becomes. But actually, it is very safe and becomes greatly simplified by the use of drug-coated balloon angioplasty instead. But good lesion preparation in these cases is mandatory. Most complex lesions can be dealt with in this manner. And in fact, as they become more complex, drug-coated balloon angioplasty becomes more appealing rather than complex stenting. Kissing and potting and all these complicated stent procedures are virtually never required. And I think the kiss-kiss strategy works quite well, which is obviously keep it simple, keep it stent-free. So that concludes my talk on bifurcation angioplasty, and we'll now move into the discussion section. I'm disappointed that my panelists didn't think it was a perfect long-term result, but I can't have everything, I suppose. Next time.
Good enough. So, ladies and gentlemen, we come to the end of the session, but I'd like to say some key learning points, which is crucial when you utilize DCB. And these are take-home messages that you should remember, especially when you treat patients using DCB. So we showed you 2 cases that were presented in a de novo LD stenosis with type C dissection post-balloon angioplasty, and how we waited and then comfortably used DCB. And of course, Simon's case of true bifurcation lesion, and treat both lesions in the side branch and main vessel was treated with DCB. Once again, we would like to stress that lesion preparation is key in complex lesions. And this is for all lesions, but in particular, if you want to use DCB. The current recommendation is that if you want to pre-dilate, the balloon to artery ratio should be as close, which is 1:1, and therefore you get less residual risk stenosis, and you can then deploy a DCB. Remember, DCB is only to deploy the drug and not to treat the lesion before using DCB. Now, optimal lesion preparation and with the aim for acceptable angiographic results are based on, number one, chemistry the flow must be good, there is no major dissection, and the residual stenosis has to be less than 30% post-POBA. You may need to require atherectomy devices or specialty balloons in trying to obtain good lesion preparation. And this is with the use of cutting balloon, scoring balloon, and also non-compliant balloon. As with any calcified lesion or fibrotic lesion, you should not have any wasting or very minimal wasting before you decide to use DCB. We also, with Simon's case, discussed about treating bifurcation lesions and the issues surrounding its utilization. We also had a discussion with the use of FFR, and especially with the in-stent balloon stenosis, the imaging in terms of guiding PCI. So FFR is one of the ways that you may find useful to guide you. In conclusion, DCB therapy is an attractive therapeutic option. There are certainly a number of advantages over stenting, but it is important for you to aim with the aim of getting or gaining confidence that DCB actually works. There has definitely to be a change in practice. You need to be more patient when you do these cases, because otherwise you'll just be reaching out for a stent every time. Remember, optimal lesion preparation, you must not be afraid of all dissections, because when you get minimal dissection, the risk of abrupt closure is going to be very, very small. You just need to practice and practice using DCB till one gets right, because by doing so, the conversion rate to stenting is going to be very low, and you're going to be confident about using DCB in your clinical practice. So as a final slide, DCB is certainly an attractive concept of treating lesions and leaving nothing behind. And I would like to thank my fellow panelists, Dr. Simon Eccleshall and Professor Bruno Scheller, for sharing this session with me for this PCR session. Thank you very much, ladies and gentlemen.